Thank you everybody for coming to tonight's educational forum on bladder health after spinal cord injury. This is a continuation of organ spinal cord injury connections ongoing sessions of educational forums. I'd like to inform everyone that tonight's session is being recorded so members of our community that aren't able to make it tonight can still participate. Please do not share any personal information that you aren't comfortable with being recorded. We'd like to make sure that everybody knows this is a safe space to share and respect others' opinions and experiences. Please stay muted during the presentation. With that being said, I'm excited to introduce our distinguished guest speaker, Dr. Linsenmeyer. Dr. Linsenmeyer has been the Director of Urology at Kessler Institute for Rehabilitation in West Orange, New Jersey for the past 31 years. He is a board certified in urology, physical medicine, rehabilitation, and spinal cord medicine. This webinar will include a discussion on neurogenic bladder evaluation and management, autonomic dysreflexia, and urinary tract infections following SCI. During Dr. Linsenmeyer's presentation, please direct all questions to the chat, and I will be reading them after for the doctor to answer. Thanks, everybody. And with that, Dr. Linsenmeyer, I'll open it up to you.
Okay. Well, great. Well, I will say that it's great to have a chance to talk with everybody. I'm sort of a West Coast person at heart. I did my spinal cord training over at Santa Clara Valley Hospital and grew up in Hawaii. So I have a lot of great feelings about being over there. So as you heard, these are the different topics that we'll be talking about. And I've also added in something on bladder stones as well. And so one of the most important things that first questions I often get is people come and say, why do I have problems with my bladder since my spinal cord injury? And it's actually somewhat complicated because we have both the bladder and the sphincter that have to work perfectly together in order to have a normal voiding. And so one way to sort of get a sense of how this all works is to realize that the bladder, see, I'm just going to, somehow I have the share screen on the top. Try to move it around somewhere so it's out of the way so you can all see it. So anyway, the brain plays an important role in sort of regulating voiding. And when the bladder's full and a person's in a socially acceptable sort of a situation, the front part of a person's brain then sends a signal to have the urinary sphincter relax, and then the bladder contracts. And so most of the time, the brain is sending these don't squeeze signals down through the spinal cord to the bladder. But if you have a spinal cord injury, what happens is that these don't squeeze sort of signals can't get down through the spinal cord to then tell the bladder to contract. So what happens is that the signals don't get down. So the bladder will then just start squeezing on its own. And this is called involuntary bladder contractions as opposed to having voluntary ones. Let me try to get this out of the way. I have this sort of bar on the bottom here. Are you seeing that or not really? All of you? No, good. It's the share screen bar sitting there. Okay, so anyway, with that being said, what happens when a person has these bladder contractions and the bladder's contracting involuntarily? Well, the first thing that happens is that you can get back pressure to your kidneys, or you can have a feeling of having to void frequently. And also, a person can have urinary incontinence where the bladder just squeezes and you void. Another thing is if you have an injury at T6 and above, a major concern is autonomic dysreflexia. There's another area that's just above the spinal cord in the lower part of the brain called the pons. And what this is involved with is actually making the urine sphincter relax when the bladder is contracting. So what happens is that when the bladder normally is going to squeeze, the pons send a signal down to the sphincter and it says, stay relaxed. And then the bladder will, when it contracts, the urine just will flow out. So that's sort of a normal situation. But if you have a spinal cord injury, what happens is the stay relaxed signals from the don't get down to the bladder and to the sphincter. So what happens is the sphincter won't open. And if it does open, it doesn't stay relaxed very well. So it sort of, opens and shuts periodically. And what happens when that happens is we have a term for that, and that's called detrusor sphincter dysynergia. Instead of it being in synergy, it's in dyssynergy. So what happens then? Well, then the urine often won't come out, and that's retention, or the urine stops and starts, as I had mentioned before. And of concern is that you can have a very high pressure in the bladder, and then this causes high pressures in the kidneys. And also what can happen is you can have this dysreflexia occurring because that sphincter is clamping down. So these are the different centers. We have the higher centers that help say, don't squeeze. We have our pontine center that keeps the sphincters relaxed. And we have then our lower area, it's called the sacral centers. And that's the ones that are in the lower part of the spinal cord that actually send the signals that make the bladder squeeze. And so if that area is knocked out, and that has a person with a low, let's say a paraplegia or cauda equina type of an injury down lower down, that knocks out the sacral center. So then the bladder usually won't squeeze. And then what happens is you get an underactive bladder, you get retention. And voiding, if it occurs, is usually just so it would be overflow, sort of like a bucket that fills up with water and the urine spills out over it. Another thing that you hear a lot about is neurogenic bladder. And what is that? Well, actually, a neurogenic bladder is a name given to a number of different bladder problems in people who have a lack of bladder control, and that can be due to a problem from the brain, from the spinal cord, or even a nerve problem. So it's important to know that this is not a specific term, and it can include a person having an overactive bladder, an underactive bladder, or no bladder contractions at all. Another thing that's important to be aware of is if you have an injury at T6 and above, it's the possibility of autonomic dysreflexia. And when I ask people about autonomic dysreflexia when they come for their bladder testing or to see me, especially when they're first injured, they really aren't sure what that is. And this actually, unfortunately, includes a lot of healthcare providers that aren't aware and don't work with people with spinal cord injury. So let me just review that real quickly, and so that then you can teach your healthcare providers that may or may not know. I often say that part of when they're acutely in rehab is one of the major goals is to learn about everything so you can teach the doctors and the nurses. So that's an important area. So anyway, what happens is we've just have some new guidelines that have just come out, and we've decided to say that a person's having some dysreflexia if it's 20 millimeters of mercury above their normal blood pressure. And that doesn't mean that they're having a full-blown headache and sweats and terrible dysreflexia, but there's something that's not quite right. So if it's gone up that high. And the other thing is important to always point out for people is that normally you expect a person with a high level injury to have a blood pressure between 90 and 110. So the most common causes are the bladder from getting overstretched or from having bladder contractions or that sphincter that was dysynergic. The bowels can also do this if constipation or impaction, or most people even during a bowel program will have some dysreflexia. And there can certainly be other reasons at all, other things, ingrown toenails or some sort of noxious stimuli, anything at all. Another thing is childbirth, and more recently we've had some papers that are pointing out that even breastfeeding can set off dysreflexia. Well, as I said at the very beginning, I grew up in Hawaii, And this was one of the favorite places that I love to go snorkeling. This is Hanama Bay. It's a beautiful reefs right in this area, and it's shallow and it can be a great place. But one of the things that would sometimes happen is that a moray eel would suddenly pop its head out from the coral reef. And this would set off and I'm going to explain sort of dysreflexia at this point, a fight or flight response. And what happens is that the sympathetic system will actually involuntarily get ready to prepare actually to get away or to fight or whatever is needed. And what happens is the person's pupils dilate so they can see better, their heart rate increases, the blood then gets pumped to the muscles and to the brain so that you can take care of whatever you need to. Well, how do you get the blood from flowing everywhere to the muscles and to the brain and all the areas? Well, our intestines are loaded with lots and lots of blood vessels, as you can see here. And so what happens is that during a sympathetic response, these blood vessels will all squeeze, and the intestines can actually squeeze that blood so it goes out of there and gets into, makes your blood pressure go up. And so this is sort of an example of what happens during that sympathetic response. The intestinal blood vessels constrict, and then the blood, flows into the rest of the body. Well, we don't want the blood pressure to go too high. Unfortunately, we have a parasympathetic system, and some people nickname this as the rest and digest system because it causes everything to relax. And so when the blood pressure starts going higher and higher and higher, we have these receptors up in the neck. It's called baroreceptors in the carotid arteries. And they signal and say, uh-oh, we need to let that blood pressure go down. And so they send a signal through the T7 area down to the intestinal blood vessels, and they tell the blood vessels to relax. But so in the perfect situation, what happens is the parasympathetic is keeping the blood vessels from making the blood pressure too high, and the sympathetic system is squeezing to keep things just right so that you can have some blood to the areas you need to have it to. But if you have an injury at T6, you no longer have the parasympathetic coming down and relaxing the blood vessels. So the blood pressure will just keep going higher and higher and higher. So that's really what autonomic dysreflexia is all about, and why we sort of find T6 is sort of the magic number of where in most people, the blood pressure goes up. And you can get online, it just came out, our new clinical practice guideline from our Spinal Cord Consortium. The Paralyzed Veterans of America has a number of different guidelines, and they're free downloads, both consumer guides and professional guides. And this is one that's, I think it's really helpful because when we were putting this guideline together, what we did was it's called an executive summary, which is just a couple pages that goes step by step of what to do. So if you're ever going to have a procedure done or somewhere that you're not really comfortable, that the people may know a lot about dysreflexia, that then you can have those couple pages with you, and then people can know that yes, there is such a thing as dysreflexia, number one, and secondly, what to do about it. So here's another question that people sometimes ask is, why do I have a risk of kidney damage with a neurogenic bladder? Well, we have the upper tracts, and that's the kidneys and the ureters that come down, and the lower tracts. And I always say what happens in the lower tracts can affect the upper tracts. People sometimes forget that. And what happens is you have these boluses of urine. It sort of squirts down, it squeezes the urine down into the bladder. And then when it gets down to the bladder, it then goes in. And it goes through these little openings. They're called the ureteral orifices that goes through. But what's important is that to get to that little opening where the urine comes out, the ureter actually is sandwiched between two layers. We have the muscle layer that's on the underside, and we have the surface of the bladder on the top side. So that this is actually can be a good thing if somebody's coughing or sneezing, because you can see when you have any pressure, it pushes down on this like a valve and keeps urine from squirting backwards up into the kidneys. So that can be a good thing. However, as you can see, if you have a high pressure and dyssynergia or something going on, that can be pushing down constantly for a long time, and that's why you get the kidney damage. And this is actually just a picture through a cystoscope, and I sort of tried to point out the best you could, sort of where that ureter is sort of tunneling underneath this, just the surface of the bladder, and the urine won't be able to come out at this point if there's a lot of pressure in there. Another analogy I sometimes tell people is it's kind of like a garden hose going from your kidney down to your bladder. And if you have a high pressure, then basically what happens is it's like putting your finger on the end of the garden hose. And so you have that back pressure. So sort of the message I wanted to pass on is that due to the configuration of that ureteral vesicle junction, that it's the high pressures in the bladder that can cause poor drainage and then blockage over time of the kidneys. So our goal is to have a nice, quiet bladder. So with that, I wanted to now go over some of the ways that we use to evaluate the bladder and to sort of make sure there aren't problems that are going on. And so first, let's go over the bladder and the sphincter evaluation. Unfortunately, the bladder is a very poor historian. It won't tell us how hard the bladder is squeezing. It won't tell us if the sphincter is clamping down real tight or just a little bit to let the urine out. And it won't even tell us why we are having urinary incontinence and why we're having leakage. Maybe it's from an overfilled bladder, or if it's squeezing too hard, or a weak sphincter. We don't know because it's a poor historian. So we need to do further tests. And the mainstay is urodynamics. And you see this is a urodynamics machine, and sort of right next to it is this is the blood pressure monitor, which is very important that we're just checking blood pressures throughout the whole thing as well. The catheter that we use is about the size of a spaghetti noodle. It's very flexible. In fact, there's a spaghetti noodle on the top, and there's the catheter, and compared to a pencil. So when it is inside, even a person with complete sensation really isn't aware that that catheter is there, so that everything should be able to be, person doesn't have to be, going, oh, this is uncomfortable and having discomfort during the test. And then the catheter goes into the bladder, and there's one opening that measures how much pressure is in the bladder, and the other one will actually let water go into the bladder so we can pump the water slowly in the bladder. And on people that we think might push and bear down to urinate as well, we use another catheter in the rectum, and it's about the same size as what I showed you. And so that you can tell if the pressure goes up or down, whether it's from the bladder squeezing or from a person pushing. And this is sort of what a normal urodynamics looks like. The bladder fills up, and then a person feels full, and then they're told to void. And when they're told to void, the first thing that happens is the urine sphincter relaxes. And when that sphincter relaxes, the bladder then squeezes, and you see on the top a nice, good, strong flow. That's the urine coming out, the blue. Well, when you have involuntary contractions and dyssynergia, the bladder just is sort of firing off on its own. And the sphincter then, in this case, is trying to keep the urine from coming out when it's not supposed to. So it's clamping down. So you can see what the urine flow looks like. There's this sort of stopping and starting sort of a event that's occurring. And you might wonder, I wonder if the person's just pushing a lot. Well, if you look down at the abdominal pressure, the green, you can see really that's a pretty flat line, that they were not doing a lot of pushing, that this was just the bladder that was squeezing on its own. This is another situation. This could be that person with that sacral injury down low. The bladder won't squeeze at all, and so nothing's happening. So another thing about urodynamics is really a great way to determine if a person gets autonomic dysreflexia during filling and during bladder contractions. And if so, everybody I found their dysreflexia is different. Some people have sensation and know when they're dysreflexic, some don't. Some get dysreflexic feelings with a very low blood pressure and some with a very high blood pressure. So urodynamics is excellent for this. And this is another thing study that we had done. And we looked at people with blood pressures, and we always do, but this was early on. And when we did this study, we found that 78% of people with T6 injuries do have some dysreflexia during their bladder squeezing and during voiding. So the majority do. But what was really interesting is that 43% of the people didn't have any idea that their blood pressure was going up. And it wasn't just going up a little, it was going from like 117 all the way up to like 170 almost. And this test, it wasn't just because of the test, this actually tests what happens in the real world. So now that we knew that, we could tell them that they do have what we call silent dysreflexia. And also we can give them some medication to help relax the sphincter a little bit more or do something. And most importantly, when a person is having some test or something done, they can tell their doctor that they might not know if they're dysreflexic and to please make sure to take lots of blood pressures during whatever procedure is being done. And this is just sort of an example, as I was talking about. Notice that second blood pressure was 114 over 80. And here's the bladder starting to squeeze. And the sphincter is sort of clamping and relaxing. So the urine's off and on, coming in and out. And there's that blood pressure. It's going up to 160. And then as the squeeze goes and the bladder's emptying, the bladder relaxes and the blood pressure comes back down and it's 140. And probably if I took another one, it would have gone back down to 120 and down back to the resting blood pressure. So the take-home message really is that a fairly large number of people with spinal cord injury, T6 and above, do have silent dysreflexia. And therefore, it is important to make sure the blood pressure gets monitored during procedures, even if person's not having any, if you're not having any symptoms of dysreflexia. Another thing is cystoscopy. And this is where we look in the bladder and we can find different things. A person with an indwelling catheter may have some eggshell little stones in there that we can see and take care of. And I'll be going over that a little bit later. Here's a person on intermittent catheterization and they accidentally pushed a pubic hair in, not even knowing it. And here it is all calcified with the hair. Here's another person which had much bigger hairs. They hadn't come in for a while for evaluation. And when I broke those open, if you look real closely, you can actually see those little hairs that were right in the middle. And then the stone just formed right around it. You can see those layer after layer forming. So even a person on intermittent cath can get stones or have issues. So cystoscopy is an important part of the test as well. And finally, this is a person that had a lot of long time history of their bladder squeezing, and they have this scar tissue. It's called trabeculation. So we can see this and we can go over it with it and then work on getting their bladders to relax so they don't get any more of this kind of tissue. Another test is to see if urine goes backwards into the kidneys, and that's called reflux. And some people can do this. They do it with a video camera right at the same time of the urodynamics. Or the other way you can do it is just do a separate x-ray, just fill the bladder up and take an x-ray and see if the urine's squirting backwards. And this was a person from many years ago, and you can see that urine is going right up into both kidneys. So just a minute ago, I was telling you how you don't get reflux. And in other words, you get a blockage from too high a pressure. So this is what happens and why you can get reflux. Some people are born with a ureter that doesn't tunnel along underneath the surface as the way it's supposed to. And some people have said that's about 5–10% at least of people who have that. So in that situation, you can see that if the pressure builds up high in the bladder, or you fill the bladder up, the urine will squirt right up into the kidneys because there's nothing stopping it like before. I usually get a pretty good sense of people who have that, even just by talking to them, because that's the person that every time they get a bladder infection, or not every time, but often, will get a high fever. And fevers aren't from bladder infections. If somebody has a fever, it's because they have a kidney infection. And so we can know that that person, if they have reflux, is particularly important that we keep that they keep their bladder empty, they keep a nice relaxed bladder, and if they start to get infection, that they get treated right away so they don't have it go up into their kidney. And here's an example of that. The normal position should be where that blue arrow is, but you can see here that it's way back. It's almost up against the back of the bladder. So you can imagine that anytime that bladder squeezes, it's going to squirt right up into that kidney. So now we'll go into the next part of how do we check the kidneys? Well, there's sort of two ways, and the most common way and the best screening test we use is a renal ultrasound. And that will evaluate to see if the kidneys are stretched. It also is great because it'll tell us if there's any stones. By the way, the stretching of the kidneys term is called hydronephrosis, and we can get a good look at the anatomy. There's another test, and we used to just do this right at the same time, but nowadays, most of the insurance companies request that we have an abnormal ultrasound before we get a renal scan. And this is what a renal scan looks like. And what happens is a nucleotide, it's the sort of same things as a cardiac stress test or something. It's squirted into the vein and it passes through the kidneys. And you can measure how fast and how well the kidneys work. This actually picks up if their drainage isn't going down smoothly, even before the kidneys start to stretch up. But currently we are using it if we see a kidney that has hydronephrosis to see if it's because the kidneys aren't functioning well, or if we just say we want to see how your kidney function is, you get a renal scan. So another thing is, well, how often should I get that evaluation? Well, there's no really clear studies on how often to do it. In the VA setting, and what we do at Kessler is that we usually do that on a yearly basis, but maybe the reason there aren't any good studies is some people may need it a little more often or maybe a little less often, but we tried to figure that out at least by our people that come in once a year. So we had 100 people who just came in for their usual testing, and we and you can see one group, these are ones that voted with control. The IC were those who catheterized themselves, the reflex voiders, those who had a superpubic tube, and those with the Foley. And we found that, and these weren't people just coming for their first time. They had to at least have had 3 years of testing so that we had a pretty good idea that things were stable. And in each of those, that about 40% or so had some type of an intervention that was needed after the test. A number of people would sort of decide to kind of lower the amount of medicine they might be taking. Some of them may have had a problem with more dysreflexia than they'd had before, so it wasn't directly related to their bladder, but as you know, the bladder picked that up. And it was really a bowel problem that was causing. So we were able to find, but essentially the urodynamics was very helpful. And we thought, well, maybe it's just helpful right at the beginning when a person first gets injured. So we looked at 2 years, 6 years, 10 years, and greater than 16 years. And the numbers still seem to come out about the same, at about 30 to 40% of the time, people did have some fine tuning that was needed for their bladders. So now I'll go over a little bit about bladder management following spinal cord injury. And there are many different types of management. And the most important thing is that there's no perfect management that's best for everybody. And so there are advantages and disadvantages for each type of bladder management. And when we were making guidelines, we actually made a guideline, which I'll show you in a minute, that actually, this, rather than trying to say this is the way you should do it or that is the way you should do it, is we went just over the different managements and the pros and the cons of each one. But the goals in all of these managements is to try to keep healthy kidneys, to try to keep from having complications from the lower tracts, and most importantly is to have a realistic management that allows you maximum independence and that will fit the best into your lifestyle. So not trying to force some method on that it won't work well for you. And this is just a list of the more common types of management with intermittent catheters, indwelling, Foley's, Superpubics, Reflex, voiding being probably the most common ones that are used. And this is that guideline that I told you about. And this is in, again, the Paralyzed Veterans of America. You can go to the Spinal Cord Consortium and it'll go over all these different managements. This is from a number of years ago. Things haven't changed a whole lot, but so you will get a pretty good idea on the pros and cons of the different things. But anyway, what I'd like to do is now go a little bit into some of the misconceptions. And I'm going to actually, in some of these questions, ask you questions. We don't have a way to have all the answers tallied up for this talk. So you can just sort of, in your own mind, just sort of think what you would think the right answer is. And then I'll go over what it is. And I'll go over a little bit about management as well. So first is intermittent cath.
We could have people post their responses in the chat if they're able.
Okay, well, I'll just be sort of going off over it. So I think that's okay, just for people to sort of have an idea with it. So with intermittent catheterization, basically, we consider that sort of the gold standard for people who can do the catheterizations. And there's one that's sort of a self-contained system where it's in a bag and you slide it out into the bladder, and that's considered a more sterile type of a technique, certainly. And the other type is a freestanding, in a sense, kind of a catheter. It may be coated with a lubricant or different things, but these are the two major types. So here's going to be my first question. True or false? If you're having trouble trying to pass a catheter into your bladder, it's best to try a larger diameter catheter. The answer is actually true. And this is surprising. And the reason is that people with spinal cord injury often have a non-relaxing sphincter. Remember, I talked about that dyssynergia. So if you start to go down much lower than about a 14 French catheter, that catheter is just going to kind of bend on itself and twist and turn. Whereas if you can go up a little bit on a catheter, that being that you don't have a scar tissue and stricture, and most people will know that because somebody's found that during it. But if you just have that tight sphincter activity, it's better to use a little bit larger catheter so it doesn't sort of twist and bend on itself. And the analogy I sort of use is like if you know those pickup sticks, if you tried to slide one of those thin little pickup sticks up the urethra, it would catch on every little nook and cranny on the way up into your bladder. So that's the same sort of an idea, whereas if you had a bigger type of thing, it would slide in past everything easier. So what do you do if you have trouble and that catheter won't go in? Well, here's a few things. One is if you feel resistance right at that sphincter area, just hold it there. Don't try to force and push it. I just had a person today who said he tried a year and a half ago to do it, and he poked right through his urethra and had a lot of bleeding, and that's really what happened. But instead, you just let it sit there. And usually after about 20 or 30 seconds, that sphincter that's clamped down will kind of relax. And then at that point, you can slide it in. You can also talk to and get prescriptions for different medications that will relax the sphincter. And the most common one we usually use is called Flomax or tamsulosin. Another thing you can use is lidocaine jelly, and you can squirt that in, and that kind of numbs the bladder. The only problem with that one is that jelly often then kind of backtracks up into the catheter a little bit. So when you slide it into the bladder at first, nothing might come out at first because there's that jelly, but it is soluble. So you just sort of push or cough a little bit, it'll blow that lidocaine right through, and then the bladder will drain. A few other things, sort of more of a preventative thing, would be that just to not let the bladder get over distended, because the bladder sphincter tries its best to keep you from having incontinence and voiding. So the more that's in the bladder, the tighter the sphincter gets. And so another thing that you can do is avoid constipation, because the rectal sphincter is the same idea. It tries to keep you from having a bowel program, and it is connected very closely to the urine sphincter. So if you're real impacted and constipated, both sphincters can clamp down and tighten. So those are some things you can just do to help prevent the urinary sphincter from having a problem. And then we do have some other types of catheters and things that can be used, but those are just the things that I think work for most people. So here's another question: true or false? Letting the bladder get overstretched will strengthen the bladder. In other words, sort of the physical therapists, no pain, no gain. Everybody's heard that, by the way, when everything comes down the first time. So I guess the therapists really make sure that they know that quote. And the answer is false. The bladder is kind of like a balloon. And so if you sort of let that bladder get stretched up a lot, it's going to actually get sort of weakened, sort of like a balloon. And when it deflates, it can get a little flabby. So you don't actually exercise and strengthen the bladder by letting it get overfilled. And so that's another misconception that a number of people have. So now I might switch into a couple of things on indwelling catheters. And we have our urethral catheter, and we have our suprapubic catheter. And the question is, first of all, when should I have an indwelling catheter, or who should have an indwelling catheter? Well, these are the guidelines that we sort of came up with people where you might consider, you don't have to, everyone is different, but consider an indwelling catheter. The first and probably the most important consideration would be a person who cannot catheterize themselves, who is not independent at lower extremity dressing. Another one would be a person who doesn't have a willing caregiver who can help perform the catheterizations. The reason for those first two are that often it's difficult to have somebody just having to be there ready to catheterize all the time, or vice versa, for a person to not be able to go and do the things they want to because they have to be around just in case they do have to be catheterized. So that would be two reasons. Another one would be certainly if you have a false passage and a big pocket in the urethra where the catheter would get caught up. Another one's if you had a really little bladder, 200 cc's or so, you'd be having a cath every, half an hour or so to, or limit your fluids to almost nothing to be able to have a reasonable length of time between catheterizations. Another reason you might have an indwelling catheter is if you have an intravenous put in, and often people temporarily might have a catheter if they have a intravenous so they don't have to keep their bladder catheterized and keep from getting overstretched. And there's some people who might whether just don't want to cath or they have a lot of pain when they cath, and so that would be another reason. For the indwelling catheters, we say to use a small catheter. 14 or 16 would be the largest we try to have anybody ever use. And if you have a suprapubic catheter, we like a little bigger one so it won't bend and kink on itself, so 24 French. Another important thing to help keep from having infections and we'll be going over a whole lot of infection in a little bit, is to not let the bladder drainage bag get more than half full, because that drainage bag has a valve on it. And if it gets full, the pressure builds up so much in the bag that the bladder gets overstretched, and the stretched bladder is what causes infections. Generally, people can't change every month, but if people are having stones or problems, we have them getting their catheters changed every 1 to 2 weeks. You can reuse the leg bags, and usually we say a very dilute Clorox solution is what a lot of people use. It can be very inexpensive. One tablespoon in a gallon of water will usually be enough. So you don't have to do a whole lot for all kinds of fancy rinses. Unfortunately, insurances usually give you 2 new bags and 2 night bags every month. But we can get certain exceptions to that if people are getting stones or having some problems. And another important thing is to prevent, we say don't take prophylactic antibiotics to try to prevent infections. That can be a problem, but we do allow and say it's good to sometimes take something called mandelamine or Hiprex. It acidifies the urine. For some people that works better. We'll talk more about that. Just a few more words on the superpubic catheter. The superpubic catheter in some ways I consider sort of an upgrade from a urethral catheter. It's much easier to change. You don't have to lay down and get your clothing taken down to change it. It can be done sitting right up in the chair. It's a bigger catheter, so there's less blockage. It's much easier to clean the perineum, and particularly I think for a number of women with menses and things, having a Foley catheter is not easy if it's going through the urethra. Sexuality, I have a number of men who have had an indwelling for many years and doing great with it, and say, I have a significant other and I don't like this catheter. So you can switch to a superpubic. So that's another reason. Another very important thing that most people aren't aware of is that you have much less infections than a urethral catheter. And finally, you have less discomfort for many people if you have sensation. In terms of just catheters, if you can't cath yourself, this is one study which was interesting, and it found that only 20% of people who initially were put on intermittent catheterization when they were discharged from the hospital were still on intermittent catheterization. But in another group where people couldn't cath, 70% of those who started with an indwelling catheter were still using that. And another study that asked about catheters said that 80% of the people with tetraplegia preferred an indwelling catheter for both social and for practical reasons. So these are just some of the things that are considered by people as well. But remember, I said advantages and disadvantages. If you have a catheter, there's a higher risk of getting bladder stones. Your bladder does get smaller. So if you're saying, well, I'll try this for a year or two, and if I don't like it, I'll do intermittent cath. Well, the bladder is very small, and it's difficult to try to convert to back to intermittent cath if that happens. And there is a higher risk of indwelling if you have an indwelling urethral, not a superpubic, but urethral catheter. Things, obviously, you can get dysreflexia if the bladder's not relaxed with anticholinergics, but that's with intermittent cath as well. There could be trauma, and I'll be going over that in a little bit. Or you can certainly get blockage where they get dysreflexic or a bad infection. So you can see that indwelling catheters aren't the perfect alternative either, but is a method that can be used. So here's another one. True or false? Superpubic catheters need to be changed by a well-trained professional. And the answer to that is actually false. I don't know what happened here. Let me see. I got into the, let me try to get that out of the way. Here we go. Okay. So what happens is that the concern with the suprapubic catheter is when you're passing it down through the tract, it can go straight down and go right up into the urethra. And then if it's blown up, the balloon, it can be a real problem with bleeding, sepsis, everything. And it can be such a problem that a lot of hospitals that don't, especially aren't familiar with, have a rule that only a urologist can change a suprapubic, and or only a doctor can do that. And because it could be such a disaster if this happens. So, but there's a very simple thing to do. And in fact, when I give my lectures sometimes to the different urology departments with seasoned urologists that are sort of sitting there in their morning and listening to the talk, all of a sudden, when I show this slide, everyone sits up and kind of oohs and ahs. So this is what all you have to do. You just basically put a little piece of tape at the old catheter at the level right at the skin. And then you take the catheter out, and then you measure the distance because you have that tape on there, and you slide the same one in just exactly the same place. And it'll be first time every time. It just will go right to where it should be, and you don't have a problem. So this method is actually safer than the urethral catheter. And here's just a picture of a little piece of skin tape. I guess if you want to use a magic marker or something, you could do that, but we just use a little piece of tape and we'll slide it, we'll hold our finger right at that tape and slide it right down, and it goes in great. Another problem though is the urethral catheter. And if it gets tied up in the sphincter, and again, remember I said this dyssynergia, some people who aren't working with people with spinal cord injuries, they hit that spastic sphincter and it won't go any further, and they think, oh, I must be in the bladder, and blow up the catheter. And so this can be a real problem. So one of the things that's really important, and you can help to talk to your people who are changing catheters, those who have a catheter, we always say go right up to the hub, to that Y connection. Now, in a woman with a very small bladder, maybe it won't go quite as far, but try to get it right up to that area, then blow up the balloon, and then you can gently pull back to where it's supposed to rest. But so the Foley catheters, you go to the hub, the other ones you measure. And that's sort of the summary here. Mark the depth and put before changing. But in the urethral catheters, always go right up to that Y connection before blowing up the balloon. And if you don't get up there, don't blow the balloon up. Pull back, do whatever else needs to be done until you're sure you're in the bladder. So another method is the reflex voiding, where an external condom catheter is put on and then a leg bag is worn. And a true or false. Newer adhesives have eliminated the risk of an external collecting device from falling off. And the answer is actually false on that. And the reason is there's an awful lot of reasons that catheter can come off. And here are a few of them. The first one on the top is if that tubing happens to get twisted around a couple times, it will actually like pinch that whole condom off, so that when the person voids, usually the first void, it'll kind of fill up the whole area and stretch it up and loosen everything. And then on the second bladder squeeze, the second void, it'll pop everything off, which can be extremely embarrassing or very frustrating to happen anytime. Another problem is even with a great adhesive, if that leg bag gets really, really full, there's enough weight that it can sort of be yanking and pulling. And this can also often cause some issues with the skin on the around the penis as well. And finally, if somebody's using some sort of a cream or something for their skin, just a moisturizer, which is often a nice thing to use, that it will often not allow that adhesive to adhere, so that can make it fall off. So these are a few of the common reasons that it might fall off, and things to be sure to try to avoid. Another type of bladder voiding is called bladder expression. and there's Crede and Valsalva voiding. Crede is where a person actually pushes on their bladder. And actually the way that some people are taught is to make a fist, push it right into the middle of their bladder and then push in and bend down. So you just sort of push the side of your fist. So maybe I'll try to hold my hand up if I can find it, like so. And you just sort of push it in like so. And that is the Crede. Now Valsalva voiding is where you bear down and push to let the urine come out. And so here's a true and false. Bearing down to push the urine out will help to teach your bladder to start working again. And the answer to that is actually false. We have, and I sort of alluded a little bit to that earlier in the talk, a guarding reflex. We all have that. And what happens is that whenever our bladder gets really tight or has pressure in it, the sphincter will sense that that's happening, and it will clamp down really tight to keep us from urinating. And that's why somebody might lift a box and it clamps down real quick, and so they don't urinate. And if they have a good strong sphincter, they're coughing or laughing, it won't come out. Now, if you have a weak sphincter, that guarding reflex doesn't work as well. But we have a guarding reflex. So that's the first thing to know about. And so this is a situation of a person who was Valsalva voids. And you look at the blue line, that's where the person's pushing and trying to get that urine to come out. And on the bottom is the abdominal. And so we know it's from pushing because they're both going up and down together. So he's pushing and pushing and pushing, and it's up and down and up and down. And now look at the top, the urine flow. Remember how we saw a normal, a nice blue flow? Well, on this one, there's no flow at all, even with all that pushing. Eventually, he did start to urinate. But the point is that that guarding reflex was doing a great job at holding that urine back, and he had to push extremely hard to really get it to come out. And so that's one of the real concerns. Now, what else is a concern? Well, hemorrhoids from pushing and straining can be an issue. That can be an issue anyway. A lot of people with injuries because of their neurogenic bowel or hernia. And in fact, it's interesting in able-bodied men who have hernias, and they will check and see if they have a large prostate gland. And if the prostate's blocking, they don't fix the hernia. The first thing that's done is to fix get that prostate opened up so that they don't have to push anymore, and then fix the hernia. Because if you do it the other way around, it'll just pop open and another hernia forms. Now, here's something I read that was kind of interesting. It's really, I'm sure, very rare. And some of the residents pointed out that who really do a lot of working out that, they've never seen this before. And I have to agree that I haven't either. But this is from a weightlifting magazine website, and it talks about Valsalva maneuvers for weightlifting, because that really helps to strengthen your core so you can really lift a lot more weight. And it's said in there, the downside is specifically a sharp spike in the blood pressure, and it's not great for everybody. And it may be associated with cardiovascular problems, strokes, aneurysm, blindness, and other concerns. And I will honestly say, as I was sort of thinking about it, that some of our people who are older, when they're pushing down, those blood pressures sometimes will go up into the 160, 170 range, just really straining to push. So there may be something to this, pushing and straining a lot. But our guidelines say that we should consider really just this Crede and Valsalva maneuver for people with lower motor injuries. So some people with paraplegia that don't have a real strong sphincter. So like that sacral type of injury I talked about earlier, cauda equina. And to be honest, to consider avoiding Crede and Valsalva altogether. Now, I know some people will say, you know, I forgot my catheter, so I kind of pushed a little. I sometimes push a little bit and just get the urine out until I get to where I can cath myself. And that's a little different from what I'm talking about, where it's all the time, every time. And this would be sort of the perfect situation for this Valsalva type of voiding. This is an elderly person, and their urethra is almost, you can almost imagine that there would be leaking without even pushing, and here it is wide open. This sometimes we have to do something like a bulking agent to actually tighten up the sphincter a little bit so they aren't leaking as much. And finally, the last one I'll go over is this neurostimulation. And this is an area where people have been working a lot, and there's a lot of enthusiasm. There's a couple of new grants that are coming out on epidural stimulation and a lot of things. So this is an area that we're learning a lot about, as opposed to we have the perfect thing, just, you know, then here's the name of what to put in. So that's so this is an area where there's more to come, so to speak. But one thing we've been doing, and some other people have been starting to do, is called percutaneous tibial nerve stimulation, and that's for people with overactive bladders. And that's been around for a while. It's FDA approved, but not for neurogenic overactive bladders, just for overactive bladders. And you have to have urgency and some incontinence of urine, and a couple criteria to get this done. But this is kind of what it looks like. It's a little like a TENS unit almost. And there's a little, you can see an acupuncture needle, and it's put just a little above the ankle, inside part of the ankle. And then another little pad that's down on the bottom of the foot. And you dial this up. So a current, people usually feel a little, they don't really ever say it's uncomfortable. In fact, if it's uncomfortable, you turn it down a little bit. And it sends this current up to that sacral area of the spinal cord, and that will quiet that bladder. Now the problem is it's 30 sessions, and it's usually the FDA says you have to do it 12 times, and the insurance pay for 12 times, and so you know that it must have to take at least 12 times, or everyone would say, well, okay, well, I'll only pay for 7 times for our client. But so 12 times has been shown and approved by the FDA to make it start to work. And this was one study where they were doing it with people with overactive bladders who had spinal cord injury, and they had a medication that they were using, and they compared it, an anticholinergic, and as you know, that can cause dry mouth and constipation and different issues. So they used that, and they compared it to the PTNS. And if you look down on the bullets, it said that both of them improved the bladder diary statistically. In other words, they were holding more and leaking less. And as far as saying there's a difference, that one is better than the other, that the PTNS and the medication were pretty much the same. So they were equal. But what was interesting is when they compared the medication, that's the SS, to the stimulation, that the PTNS was not associated with any adverse events. And by adverse events, this would be the constipation and the dry mouth and these sorts of things. So it's something that is interesting, and it's just starting to be used more with spinal cord individuals. But a lot of urologists are very familiar with this because they use it for their able-bodied individuals. So in summary, there are risks of the upper and lower tracts following spinal cord injury, so that a careful evaluation and management does significantly decrease complications. And now I may switch gears a little bit and go into urinary tract infections. And I may spend some amount of time on this. And the reason is that this is the most common problem after spinal cord injury. We say an average, even if you're doing everything just perfect, is 2 infections a year. And many people get much more than that. The other thing is that it's the most common cause of a person having to go to the hospital and be admitted following spinal cord injury. So it's a very important area. So, true or false? It's helpful to have bacteria colonized in the bladder. Well, I may say this is kind of a trick question, because a bacteria in your bladder can be your friend or it can be your foe, either one. And this was a paper that's written about bacteria on the skin. And this article stated that a new hypothesis is that bacteria on the skin directly benefits the person and are rarely harmful. You know, everyone tries to get all the bacteria off and this and that. So this was considered, this is a new hypothesis. And Staphylococcus epidermidis, which is 90% of bacteria that people have on their skin, was actually found to disrupt the signaling of competing bacteria, the ones you don't really want to have, Staph aureus. That's what is not a nice one. It causes boils and all kinds of different problems. And ultimately, it leads to inhibiting the colonization of those bacteria and helps to keep them away. A analogy I use is if you have a beehive and the bee from another hive gets to the wrong hive, those bees knock that bee right out, and that's the end of that bee. So that's essentially what this does. And the same thing is felt to happen in the bladder. And in fact, Pseudomonas, which everybody go, oh my gosh, that's a terrible one, and we don't like people to have it because it is very resistant to a lot of antibiotics. But I will say that the byproduct they actually use from this Pseudomonas is a topical ointment that you put on your skin. It's called Bactroban or mithromycin, and very effective at heat treating skin infections. And actually, it's also found that this Pseudomonas suppresses fungal growth. So all of these bacteria that we have, each one has a way of trying to knock everything else out. And you'll probably notice when you get you have a urine infection. In theory, if you do intermittent cath or you have Foley, you should have just tons of different types of bacteria in your bladder. But you don't. It usually comes out 1, 2, maybe 3 different types of bacteria. Well, the reason is that those 1, 2, or 3 bacteria are working full time to keep everything else out of your bladder. So it's felt that the urinary tract is inhabited by a unique urinary microbiome that's felt to actually have a role in the health of maintaining your bladder. And a microbiome, which is becoming more and more of a term you've probably heard and will hear, is actually a group of bacteria that all live together and help in a good way. However, in those with a microbiome having urease producing bacteria, and these are the common ones, Proteus, Klebsiella, this type of bacteria can make the urine very alkaline and make you get stones either in your kidneys or in your bladder. So this would be obviously a foe. So an understanding of colonization is also very important to know of when to treat these bacteria. Is it a colonization that you want to keep or not? And so this is a definition that was developed that I think is a very good one. And that is that you have to have 3 different things before you treat. First of all, an increased bacterial count. And almost everybody will have that if you have a catheter or do intermittent cath. Also increased white blood cells. And most people, if you pass a catheter in and out, they'll have some increased white blood cells. But the most important thing is the new onset of symptoms. And so, for instance, if every day you wake up and you just have a little bit of mucus in your urine, or it's a little clouder every morning, or it has a certain smell every day, that's not an infection. That's just the type of bacteria that's living there. That's what it does. But one day you wake up and a horrible odor, spasticity, dysreflexia, whatever, that's the one that's an infection. And that's the one where you would try to find out what's in there and what to treat. So there are good reasons why we don't want to treat the asymptomatic bacteria, because that can disrupt the microbiome, do more harm than good. You can build up resistance to the bacteria, getting over and over again. And obviously, you all know side effects. You can have allergic reactions. And one of the worst things, of course, is C. difficile that some people can get, which is a terrible diarrhea and fever, and it can be a real problem. So the goal would be to have a bladder that sort of looks like this lawn, just a perfect, nice, smooth lawn, and no weeds or anything to get into this. And if you knock out those bacteria and start beating up that lawn, and then you can start to get all kinds of different things that are kind of growing in there, different weeds and things. So that's sort of a way to think about it as well. And again, it's important not to try to disrupt that microbiome unless you have a symptomatic infection. I will say that in medicine, we never say never and never say always. So I will flip back to that one situation, and that's urease producing bacteria. So even if there's no symptoms, you're feeling great, we always look and see, is there any stones in the bladder or the kidneys? Okay, if there aren't any, that's a good thing. And if there are, it's important to get rid of it, or this bacteria will never go away. But then after that, then we give a couple courses of antibiotics. And if that bacteria just keeps staying in there, then we just leave it, because that's just what the microbiome, and it doesn't seem to be doing any problems with stones or anything. But that's an exception. So another true or false. You do not need to get a post-UTI urine culture and sensitivity after being treated and getting better from a symptomatic infection. And the answer is true. And a very common misconception is that you should get a post UTI CNS to make sure that that infection's gone. But the problem is that when you obtain a routine urine culture and you're feeling fine, what it does is you're most likely going to have a positive urine sample. We already talked about that. You're colonized. And so what happens is that unfortunately, a lot of times a person will just be given more antibiotics to try to get rid of it. And here's a perfect example of a case. It's interesting, when I talked about this to one of our spinal cord fellows who was in training, the very next person that came in after I was discussing this had this situation as well. So I'm going to go over. So this was a 54-year-old woman. She had a T10 paraplegia. She came in for her annual evaluation. And I noticed in her arm, she had a PICC line. And a PICC line is actually a long IV that goes quite far down the vein, almost near the heart, so that you can get the antibiotics and you don't get infections and you don't blow the line. So she had a PICC line in place. And I said, kind of ask her about it. And she said, well, my PCP found an infection in my urine. And even after several courses of different antibiotics, he couldn't get rid of my infection. So he referred me to an infectious disease doctor. And now he's giving me 4 to 6 weeks of intravenous antibiotics through this PICC line. And so I said, well, are you having any urinary tract symptoms? And she said, no, they just keep finding bacteria in my urine. So unfortunately, overtreating asymptomatic bacterial colonization is something that I do see quite frequently. Now, true or false? Individuals are usually accurate in knowing when they have a UTI. And that's false. We had in our clinic a group come in, and we have people. I've been at Kessler for over 31 years, so I have a lot of people that know them, and they come in and out. And we said, people came in and said, I'm sure I have an infection. And we got a urine culture and we used the criteria we're just talking about above. And 60% of the time, yes, it was an infection. But what was really important to note is that 40% of the time, it wasn't an infection. And for example, the increased tone was from a bowels being too full or something else that was going on. And so this is something that's is very important to know about because, and I particularly for the healthcare providers, that they don't just call in antibiotics. And here's an example of that. This is a 48-year-old man who had a T6 paraplegia, and he called us from home, and I knew him very well. And he said that he had a high fever from a bladder infection. And he said, I just feel too sick to be able to come in. Couldn't you just call in some Cipro? Because in the past, often he was sensitive to Cipro. And I said, no, you really have to come in for us to see what's going on. But now, with the video all set up and everything, we would probably say, or you need to have a telemedicine call so we can really talk and look and see what's going on. But in that time, he got in the car and came over. And then we got a phone call from his car. And he said, I just feel so sick to come in. Can't you just come out to the car and get the urine sample and do my vital signs? So we said, okay. So he went out to his car and he had a temperature of 102. His heart was beating like crazy and he was just sweating like crazy. So we knew something bad was going on and we called 911 and he was taken right from the parking lot in an ambulance to the acute care hospital. And when they got him there, they evaluated him and he had emergency surgery and had an acute appendicitis. So again, that's a really important reason why it's to really find out what's going on. Now, fever, I'll say, is a very rare symptom of a urinary tract infection. It's only about 7% of the time. And so in emergency rooms and things call me sometimes, oh, your person has a UTI because he has a fever of 102 and we're going to give him some antibiotic. First thing I say is, no, he needs to be chest x-ray, blood work, and evaluate because you don't get fevers from a plain old UTI. And that's something that I think would be important because it's so easy when you go to the ER with a fever, they'll do a dipstick and of course you'll have bacteria in there and they, oh yeah, you got a UTI here, take some antibiotics and that's the end of it. So it's important to really rule out other reasons for fever. And nowadays, of course, COVID jumps up in everybody's mind when you have a high fever, but it's important to get a good evaluation. So true or false? Frequent catheterizations will introduce bacteria into the bladder and increase the risk of a urinary tract infection. The answer is false. And what actually happens is that frequent catheterizations has been found to decrease the risk of infections. And those who catheterized every 4 hours were found to have less infections than those who catheterized every 6 hours. And it was 6.1 per 100,000 per thousand versus almost double that if you went every 6 hours. So the more you cath, the less infections. And this is one of the reasons. This was a person named Dr. Lapides, and he's the one who actually was the first one to talk about clean catheterization, where you clean with soap and water your hands and then wash and just do a catheterization. And before that, everybody was sterile kits and betadine and everything else. And this is what he said. He said that blood flow to the bladder can be reduced by increasing the bladder pressures or by overstretching the bladder. And this slower blood flow lowers the normal defenses. That's the microbiome. He didn't say microbiome at the time, but it lowers the defenses of the bladder wall that can allow invasion then of the normal colonized bacteria into the bladder wall and start an infection. So that avoiding high pressures in the bladder and over distension is the key to preventing urinary tract infections. Another thing that can sometimes happen if the bladder really gets stretched up, you can have these little tears and in the bladder wall, and you can see, of course, the bacteria can get right into the underneath the surface. So the foe can also be your own friendly bacteria. If the bladder overstretches, those friendly bacteria can get underneath the surface of the lining of the bladder and start up an infection. So here's my motto that I use. And almost everybody knows that. Some people even repeat it to me sometimes. When in doubt, cath it out. And that's the motto that we use and works pretty well. So, true or false? A Foley or urethral catheter has a higher rate of an infection than a superpubic catheter. And that is true. This is actually a study, and we don't have a lot of what we call prospective studies. Usually people look back in charts and try to find out what happened. And those aren't as good as studies as when you look at something and decide what you want to look at and then look at it prospectively as people are coming in. So this was a very good study in that, and they had similar criteria. You had to have a 10 to the 5th bacteria, and you had to have symptoms. And look at this, what they found. Normal voiding, you had a 0.06, so very rare to have an infection per 100 days. An indwelling urethral catheter was 2.72, very high, compared to intermittent cath, which was 0.4, so that's a lot better. The intermittent cath was, the indwelling you can see was more than double that. And what's really surprising, the superpubic catheter had even less than that. It was the best of all. In other studies, it was found to be equal to intermittent catheterization. But the point is that the superpubic and intermittent catheterizations have a much lower risk of infection than an indwelling. And to a lot of people, it was surprising that the superpubics, that was the case. So again, superpubic catheters have fewer infections than any other method of management, but only by a few percentage points. So intermittent cath comes in a very close second. So why is that? Well, this is my thoughts on why it is. And that is the superpubic catheters have a larger diameter. Remember I said that 24 French, which is about the size of probably your small finger, depending on how big your fingers and hands are. And so it's less likely to get kinked. And since the tubing travels over the top of the abdomen and you're not sitting on the tubing and stuff, it goes right down into the drainage bag. And therefore, there's probably less likelihood of the bladder getting overstretched and distended from infection. A common misconception is that indwelling catheters, superpubics and urethral catheters are alike. And it's amazing that, articles are written and go to talks and presentations. And people say, oh, how bad catheters are and they cause infections and all of this. But again, there really is a difference with infection with regards to these two different catheters. So in summary, with urinary tract infections, there is a difference between bacteria in the urine and the symptomatic infection. You want to treat a symptomatic infection. And if there's a fever, then it's really important to look for other causes and not to just assume that it's a urinary tract infection. And if you do have a fever and it's from the urinary tract, generally it would be because it's a kidney infection. It's called pyelonephritis. And a person's very sick, and if they have sensation, they'll have pain on the one side of the other side of their upper back where that inflamed kidney is. Rarely you can have something really rare like an abscess or boil or something, but that's something that would be a very unusual thing. And also then the other summary part is to prevent infections by keeping the bladder from getting overdistended. So now I want to go over one more type of complication that, and the reason is it's the second most common complication, and that's bladder stones. And indwelling catheters, it's been found that about 30% of people will have stones who have an indwelling catheter. Generally, it's been felt to be from infections because there's what we call a microbiome. A film is formed on the catheter lining, and then stones form on it from the ones I showed you before, the proteus and the protoventia. So if you have to be one of the 30% with that type of bacteria, you can get stones. But here's an important point that sometimes is missed, that with regards to that 30%, that it's the same 30% of people that get these stones. So it's not like a random that everybody with catheters has a 30% chance. 70% of people don't ever get any bladder stones. So there's a 30% that do. So the nice thing about that is that in that 30%, then we can hone in and focus. We can have the catheters getting changed more frequently, look in the bladder more often to get the stones out and do these things. So that's something that's very helpful. Now here's sort of an interesting series I wanted to show you of the formation of bladder stones. I was looking through the person's urethra with a cystoscope, and they had in a superpubic catheter. So you can see the balloon and the cracks on the balloon. These are the stones where the balloon is starting to get deflated from the superpubic catheter. It's like an eggshell. Behind it, that red is just the bladder wall. So then what happens is that when that catheter got deflated and pulled out, all those little stones just drop down into the bladder. Now, once they sit there, they can easily go up and get into the eye holes of that catheter and cause blockage. Fortunately, a lot of times they just sort of lay there on the bottom of the bladder, and they're heavy enough they don't get up into the catheter, but they can have, that can happen, or you can get stones forming within the tubing itself. Another thing that we found that might be helpful for some of you is that we did a study and we found out if a catheter is pulled out and it's encrusted with sand and stones, that there's an 85% chance that there will also be stones in your bladder. So that if you have that, it's very predictive that they're bladder stones. And you can't just do a lot of flushing and get the stones out. In fact, one thing sometimes people do with their catheter, it gets all clogged. They'll start to try to blow out the stones with flushing. But if you think about it, if that whole tube is filled with stones and you push a whole lot of fluid in it, it shoots all those stones out of the catheter and into your bladder. So you have tons of stones in your bladder. So the better thing to do is if that catheter seems to be blocked, you could first gently check it. Okay, yeah, it's blocked with a little bit of saline or whatever. But then take that catheter out and put a brand new one in. And that's the way to do it. And we've tried, flush, and just irrigating the catheters really won't get the stones out. So at that point, it's probably a good idea to figure out a way to have somebody look in there and get those little pieces of stones and fragments out. And this is sort of the treatment for these small stones. I have it's called an alligator forceps, because when it opens up, it looks like a little alligator teeth, and I just break it up into little pieces and then just rinse out all those little pieces. And if it's a big stone, and usually most people's stones are small, these are actually, to be honest, these would be considered big stones. Most of them are smaller, much smaller than this, that I can just grab a couple little pieces and pull out with no problem. This would be a larger stone, maybe someone who didn't come in for a while, a couple years or something, and a couple big thick stones in there. Well, those can't be really broken up very easily. And so we use something, there are a lot of different things with laser. This is electronic lithotripsy. This is a probe. It's set up against the stone and it sends we call it a shock wave. It's not an electrical shock, but a sound wave that hits that stone. There it is going off, sending that into that stone, and the stone busts up into little pieces. And here you can actually see those layers. That first white piece was probably the initial stone, and then more stone was growing on it. And that's what happens, just like that pubic hair I showed you before, where there's layer after layer, and these stones can get bigger and bigger. So what we do, and I've showed you this picture, is that when we break up those stones, we, normally if an able-bodied person went to a urologist, they'd just bust the stones up and say, okay, go home and drink lots of water and you'll pee them all out. But that doesn't happen if you have a neurogenic bladder. You have to get every little piece of sand out of there, because those pieces will actually be like, I say an analogy, if you put a piece of sand in an oyster, it forms a pearl around it. But unfortunately, these don't form pearls. But that's basically what happens if you just leave pieces in there. And that's another reason, even like if you have a stone broken up in the kidney and the stones, little fragments are passing down into the bladder, that at some point, maybe 2-3 months later, just to take a look in there and make sure there aren't any pieces sitting in there that have to be rinsed out of the bladder. So for some final thoughts, bladder management is a major part of a person's life post-spinal cord injury. And however, a neurogenic bladder doesn't really have to restrict you from all the things you want to do. And so far, I've been sort of going over all these different complications and bladder stones and all these things. So I wanted to end with at least a couple nice pictures. And this is a 71-year-old man who is very adventurous. He's a C7 incomplete injury. And he's on a tether and he's going down the mountain, just having a great time. Here's another person who has a paraplegia, and he's actually a ski instructor. He's out water skiing. And this is a person who has a tetraplegia, and he is actually one of our first people at Catheters, part of our program, fertility program, and he's holding his newborn daughter, and she is now going through college and just doing great, and is the real love and joy of his life. And so with that, I will end, and I'm open for questions. I'm not sure what time it is because I don't have a watch on here. Casey, how are we doing?
Hey, first, I just want to say thank you. That was very informative and a lot of great info. It is 6:30 here, our time,
Okay.
so I think 9:30 your time. Are
Okay.
you, I want to be respectful of your time, but are you open for a few questions?
Sure. Why don't we have a couple questions and then then I'll close. And
No problem.
sure.
And thank you for ending on the inspirational note there.
Oh, okay. Well, it's I find it very inspirational working with people with spinal cord injuries.
Awesome. So if anybody has any questions, please direct them to the chat. And then the first one I have is, in men, does retrograde ejaculation cause infections?
No, that's sort of a little bit of a different topic. And it does not cause infections, and something that's very common. And one of the major reasons why people after injury often don't notice that they have a forward ejaculation. And the only time it becomes an issue is if you're trying to father a child, because the sperm are going backwards. But we have lots of great techniques now with assisted reproductive technology to bypass those problems.
Got you. Next is that, have there been any studies done introducing good bacteria into the bladder?
There have been studies. E. coli, they developed, Dr. Darush was his name, and colonized the bladder. And the only problem was it was really tough to try to colonize the bladder. He had to put it in and let it sit there for a couple hours, and then did it again and a couple other times. And then the people where it stayed in there was very effective at preventing infection. But the problem is that a large number of people, it kind of would wash out over time. So in other words, their own microbiome was able to beat out the one that was put in there. But the answer is yes, there is. And I don't know, some people have been trying to get some sort of a microbiome on the end of a catheter with bacteria. So every time you passed the catheter in, you would push in the good bacteria. But anyway, that's an interesting area of work. And perhaps my thought is that we're going to learn more and more about probiotics. Right now, it's just a gunshot, here, try this or try that. But someday we can probably figure out what kind of bacteria you have, what your microbiome is, and what type of probiotic is the best one for you to change it or not change it. Sort of a way that you can consider changing a microbiome that we do, and those of you with long-term injuries are probably very familiar with this, is that's the mandelamine or the Hiprex. And what that does is it doesn't kill the bacteria, it changes the urine to be more acidic and basically changes the microbiome around. So the bacteria that were very pleased with their normal environment suddenly are faced with an acidic changed environment and will leave. And often, and in fact, pretty much always, you'll get a friendlier bacteria that's there. Sometimes you still get infections, but in a large number of people you don't. So that's sort of our primitive way that until we learn more and more of changing microbiomes that have been going on for years. So yeah, that's the answer to that.
Got you. And then as you age with spinal cord injury, like 20 and 30 years plus, what things do you need to watch out for when it comes to bladder health?
Well, I think that in terms of aging, the same sort of, I think from the study that we showed before, it's sort of the same types of things that you have when you're not aging. That's not, the bladder does have some changes. For example, sometimes the bladder starts to get weaker and doesn't squeeze as hard. So you might start getting more retention. And that can be particularly a problem if somebody's had a sphincterotomy, because the bladder is no longer emptying the urine the way it should. Sometimes as you get older, you can get something called a syrinx. And that can be 10, 12 years after injury. And that can sometimes make the bladder get more overactive. It's a little cyst that can form where you were injured. We have an interesting situation of an elderly woman who for years and years has been doing great, and then all of a sudden has been just this past year infection after infection. And what we think's happened is that her vaginal microbiome, because women have lactobacillus, able-bodied women, and that's why they don't get infections. But sometimes when they get older, what happens is the pH changes and they get E. coli growing in the vaginal flora, and they start getting lots of infections. In fact, I was just on the phone earlier, a couple days ago, the OBGYN doctor and myself, we're going to have her try some special suppositories to try to knock out the E. coli and change it back to the lactobacillus. So the answer is that there are different things that can occur, but most of the infections and high pressures and hydronephrosis, all these things aren't directly related to the older you get. They're related to what your bladder is doing at any age. So, no.
In your opinion, what is the best anticholinergic?
It sort of depends on the situation. I think that different people respond differently to them. So I would say that it's best to probably, I think I'll just sort of say that studies have said that the long acting, the ones that are given that are extended release are often less dry mouth and constipation. As far as what is better, the question is what is better is, if better means which one makes your bladder not squeeze as much, they all sort of will do that. I have found that some of the ones that have less side effects don't let the bladder squeeze as much. And maybe that's why they don't have as much side effect. But it's best, what we do is we will usually, when we use an anticholinergic, we then will check and make sure that things are okay with the bladder testing and do what we need to do. There's another drug that I didn't mention in there called mirabegron, and it's a great addition to anticholinergics because anticholinergics make the bladder not squeeze. That's their main job. But the mirabegron will make the bladder relax so that you can take both together and the bladder relaxes and it doesn't squeeze. The only problem is mirabegron's about $400 a month. So insurance companies are very unhappy with that combination. And you have to have a good reason and show that you tried the other. But why I'm pitching the mirabegron especially is it doesn't cause a dry mouth. It doesn't cause constipation. So it's in that way you can potentially use that combination and maybe not have to take as much anticholinergic.
I want to be respectful of your time, so we'll do 2 more questions.
Okay.
Are infections more prominent in uncircumcised men?
There haven't really been any really good studies in people with spinal cord injuries. So I don't really have a good answer to that. I think my feeling is the most important thing is to keep the bladder from getting over distended. So the theory would be, well, why do you get more infections with circumcised person is because maybe they have more bacteria in the foreskin. But again, theoretically, those bacteria are colonized in the bladder as well. If everyone has their own unique sort of microbiome. So it's that keeping that bladder from getting overstretched and letting good blood flow into the bladder. And ways you can also do that, again, is, those anticholinergic, those relax the bladder and the blood can flow in really easily. And I'll just give one other analogy is there's some chemotherapy agents that will make the whole surface of your bladder just come off. And the person then starts bleeding and bleeding. It's called hemorrhagic cystitis. And in order to try to not have that happen, the oncologists have you alkalize the urine and do all these things. But what in the heck would you do if that was bleeding like that? Well, the treatment is you put a Foley catheter in and you start filling the bladder, filling, and you over distend the bladder, stretch it, and that stops the bleeding. So the point being is that you can shut a bladder blood flow and bleeding off by simply filling it, overfilling it. And I think that that's sort of a reasonable illustration of what, it's very effective at stopping bladder blood flow by overfilling a bladder.
Good to know. Last question. Is it common to have discharge around a Foley catheter without an infection?
it depends on the sort of discharge. Most people don't complain of a discharge around their urethral catheter, but you have a whole lot of little glands up and down the urethra that secrete mucus material. And it's the same thing that your lungs have. It secretes mucus to clear out keep things clean, so to speak. So your urethra does have that, so that you can have a small little bit of that, kind of coming out, but it's usually clear. So if it's not clear and there's an odor or a lot of it, it might mean there's something else. Sometimes people, for example, have a little pocket in their urethra, and the fluid, this stuff collects in there, and it'll come squirting out sometimes, but it's not really an infection. And sometimes it's just the fluid from the prostate. When we talked that first question about that retrograde ejaculation, well, sometimes some can come out in a forward direction. And even though the Foley catheter's in there, it kind of comes up and around the catheter and can come out. So you could have just a discharge from that. So there's a lot of different things. Superpubics, by the way, will almost always have a little bit of a discharge around them. And we actually have people cut a little piece of a 4x4, bandage, and just tape it like almost like a little apron right on the skin there, with a very loosely, with one little strip, and just so there's like I used to call it like a little smudge, so it doesn't get on the clothing. They just have that on, and just sort of a routine thing. So that I will say is very common, but not as much with the other.
Okay. And then I had one last question come in, and then we'll call it.
Sure.
When you're having symptomatic, when you're having symptoms due to a UTI, and you've done, a few courses of antibiotics, but you're still having the symptoms and it's not clearing up, is there anything you can recommend getting checked?
Well, that's when it's really important to have a good evaluation. The ultrasound is used, as I said, to look for stones and hydronephrosis, to make sure that that's the problem. You want to do a urodynamics, because if you have a small high pressure bladder, it will cause the infections to occur. And also, so the urodynamics is also something that's very helpful. And the cystoscopy is really helpful to look for any stones or anything else in there. One of the things that's interesting was a study that was done with Botox found that people who were having Botox injections had a lot less infections. And the reason that was felt to be the case is the Botox is extremely effective at making that bladder completely relax. It's like if you get Botox in your face, everything relaxes and smooths out. So having a quiet, relaxed bladder is really helpful for a lot of people. And then if that doesn't work, we do those things we talked about, the mandelamine and different things. So, but that evaluation is extremely helpful to make sure there's nothing really obvious that can easily be taken care of.
Well, with that, Dr. Linsenmeyer, I want to thank you for your time. And I know it's a lot later where you're at, but it was awesome of you to come on here and spread so much good information for us.
Yeah.
Okay. Well, it was great to be able to be a participate, and I read a little bit about your organization, and it's really great. And I was pleased to see that you have such a great group there.
Thank you.
Okay.
With that, I want to thank you everybody for attending, and this will be posted onto our website soon. I'll make sure I put the link on Facebook, but thank you everybody, and thank you, Dr. Linsenmeyer.
You're more than welcome. You all have a good evening.
You too.